Thank you very much, Mr. Chairman. It is my honor to speak to you as a member of Sejong family to talk about neuro in cardiac meeting. I spent 43 years in the United States. I came back as a member of Sejong this January and to lead our neurovascular center. As previously Professor Lee mentioned, our goal is more multidisciplinary approaches to any vascular diseases, including cardiology and neurology, and as well as interventional cardiology, cardiac surgery, and neurovascular diseases as well. So we are trying to make it new approaches and make some way of how we can deal with the neurovascular disease or cardiovascular diseases. I chose this topic, new advances in endovascular treatment of acute ischemic stroke, because both you, cardiology, cardiac surgery, and for us, neurovascular diseases, we deal with these stroke problems often, and how we deal with it, how we advanced in the last few years. And there was a big jump of this management of the stroke, not only medically for intervention-wise. So I'd like to introduce what we do for the stroke patient. We call a brain attack. Brain attack is not all the same disease. There are three major different categories. One is ischemic stroke, the other one is intracerebral hemorrhage, and the other one is subarachnoid hemorrhage, such as rupture of intracranial aneurysms. Certainly, ischemic stroke is a major portion of a brain attack. It is third leading cause of death in the United States. And there is about 5.8 million in the United States who are affected. I'm sorry, I'm not familiar with the Korean statistics yet. So I'm showing you what US standard, the statistics. So about 2,000 people die from stroke per year. And not like a cardiac myocardial infarction, the death rate is maybe lower. However, the long-term disability is much higher than what cardiac disease can give. So it costs more than $57 billion. This is statistics from the United States government. It is $57 billion per year for long-term cares. We're all familiar with what is contributing factors to stroke. Certainly hypertension, smoking, all this, you are more familiar than what I do. And one other thing is atrial fibrillation. We often see patient comes in with an acute stroke and history of atrial fibrillation, or atrial fibrillation was not managed properly. Okay? So heavy drinking or other hematologic diseases can contribute to cause stroke. The brain vessels, brain arterial systems are a little bit more complex than coronary arteries. Okay? This is the normal arterial tree, which is of the carotid artery. I will talk mostly in carotid artery systems. Carotid artery divides into anterior middle cerebral artery, which goes along this south side of the brain and goes in more distally, as well as deep vein, deep arterial systems. In case of stroke, you can see the blood clot is blocking major blood flow to this middle cerebral artery, which is causing ischemic stroke. The source of those clots, as we know, is all over from the heart until the last vessel of subclavian artery, aortic arch included. Mostly atrial fibrillation is main cause of the cardiac origin, the clots. Other diseases such as carotid artery, atherosclerotic disease of the carotid artery, can cause emboli, which can block the middle cerebral artery. Even intracranial stenosis, as you can see, this case of the middle cerebral artery, intracranial stenosis can be source of complete occlusion causing it. Especially in Korea, I found out there's more intracranial disease than the Western world. What are the symptoms? In case of the myocardial infarction, you have a severe pain, chest pain or shoulder pain or whatever, symptoms related. However, in case of brain stroke, the symptoms could be minor or could be ignorable unless you are with somebody who recognizes difference of that behavior or speech or anything. This is the American Stroke Society made this pamphlet to educate public. The symptoms, 3 major symptoms are facial palsy, asymmetry of the face, and then hemiplegia, the weakness or sensory changes of opposite side, and aphasia means you cannot speak or you are mumbling or you are not speaking well. There's no pain associated, so patients often ignore early symptoms or warning signs, okay? Except dissections. Dissections cause symptoms of the pain, neck pain or headache. There is a certain latent period of few hours to few days from the initial symptoms of the neck in case of arterial dissection. This is, a video I made a few years ago to illustrate why dissection happens, what can cause a stroke. Because of the dissection, increased size of the arterial wall itself can cause stagnation of the or blood flow and cause a stroke, which can dislodge the clot, and distally you may cause this double lumen of false channel of the blood flow itself. Let me show you one case of the dissection to illustrate this can be cause of dissections, the cause of stroke in young patients. This is 30-year-old female who had acute onset hemiparesis and aphasia. She couldn't speak. She was a feeding mother. She had a baby and she was feeding mother. And all of a sudden she couldn't speak and become weak. When we brought in, we had evidence of complete occlusion of the internal carotid artery, and when we put the microcatheter, it was clear she had a dissection, so we had to stent and reopen the blood vessels. And final angiogram shows there's a false channel. You can see the wall of the intimal wall is there, and there's false channel is formed, and this was cause of her stroke. What happens if the blood clot is occluded? Just like myocardial infarction, there's progression of cell death. Immediately after, you may not see any cell damage. However, it progresses until 3 hours. In 3 hours, most of the oligemic and ischemic area become complete dead. And Dr. Saver, he calculated in relationship with the amount of the neurons what we find in brain, and he calculated this 1.9 million neurons die per minute. So it's a very rapid progression in case of the ischemic event. It takes about 6 to 18 hours to have a complete death of the territory of the brain. And depending upon presence of the collateral, or in case of sufficient collateral, you may not go to the complete death. However, how we manage it, the sooner the patient gets, is the better. Okay? So this is a management cycle, what I borrowed from one of my colleagues. Okay? Once you arrive in the emergency room with a stroke, we certainly had the diagnostic workup done, and then we used to treat this as a stroke unit. Before all this newer development, we used to do the general medical management, some steroid, to use heparin or anticoagulant. However, there was a new treatment developed, so-called Tpa Infusion. This is NINS trial. This is a National Institute of Neurological Disease and Stroke. They initiated this clinical randomized trial using intravenous infusion of the TPA tissue plasminogen. So they found And there's a significant increase in neurological recovery and reduced incidence of disability when treated within 3 hours. Okay? This was become standard of treatment until recently, which I will introduce. All these years was developing, we also, interventional neuroradiology, started treating the stroke patient by infusing. There's no organized trial. However, we tried, each physicians tried to treat the acute stage by infusing the urokinase. We used a urokinase slow infusion at the face of a thrombus to 1.5 units. This is one of all the examples I did. This patient came in with a complete occlusion of middle cerebral artery, and this was infused with the urokinase. You can see complete recanalization of the middle cerebral artery territory, dissolving the thrombus completely. This is follow-up CT scan. It's just a contrast stagnation, not real hemorrhage. So this was a 1 year cycle of that result I experienced when I was working in the Massachusetts General Hospital. So actually, we did have about 50% of the patient recover better than the neurological, just a medical management. If you look at it, there's excellent good outcome at discharge was just about 50% of those patients we actually treated. Some patient died and did not recover at all. There's other trials since that period, and PROACT 1 or PROACT 2, this is a pro-urokinase trial. This is 1999, was published. Unfortunately, this not give a dramatic result to get approval from FDA. The other trial was a Clot. Mechanical device was used in 2006 to actually improve the mechanical removal of the clot itself. It was a relatively okay device. However, clinical result was a little bit better than the intra-arterial infusion, so this got approved by FDA to use in clinical use. But tools were not sophisticated. It was more difficult to use, and the results are, so and so. The other trials happened, so-called interventional management of the stroke, 1 to 3. This was initiated by Tom Tomsick, who's in Cincinnati. But the result was so-so. It was not great to improve it. Until 2015, there's publication of so-called Mr. Clean trial. This is organized by Dutch people, and they had a multi-center trial of using infusion of the TPA IV infusion versus intra-arterial infusion and mechanical device. This time, the difference was using stent retriever. Stent retriever is the one which is actually suctioning out and taking out the blood clots at the time you get into the arterial tree. That result has a better recanalization rate, and also this is MI modified Rankin scale. It means a stroke recovery, okay? Result of the recovery. 0 to 3 is the independent living. It's a 33% versus the intravenous treatment with the TPA. You remember, as I mentioned, TPA infusion was better than just medical management, but this intra-arterial treatment with the devices was much better than the intravenous treatment. So the paradigm is completely changed. Now mechanical device is becoming standard of treatment in the acute stroke patients. Okay? What is mechanical devices? There is 2 types. Okay? There is a stent. This was actually designed to treat intracranial aneurysm with a wide neck, but somebody find out that this can be clot removal. The other thing is development of this the large lumen catheter. This is actually 6 French catheter which can be navigated into the middle cerebral artery. We were, few years ago, we were not imagining putting this huge pipe into the middle cerebral artery, intracranial vessels, but this changed the whole management of the stroke patient. The idea is you place the stent across the stent, the thrombus. Okay, you wait about 4 or 5 minutes until embedded into that clot, then remove with this stent. So this is one example of we took it out. This is the example of the suctioning out. You put a large 6 French catheter in front of the face of the clot, then you suction. And then you take it out, you can see there's a large, almost 1 inch of the clot was taken out by this suction. So you create immediate recanalization in case of the complete occlusion. This is patient who had a complete recanalization after the suction out with that clot. That's 2 major devices which can be treated, which are applied in a stroke patient which changed. So patient comes in with with the acute stroke. First we do is CT scan to rule out whether this is ischemic stroke. This is patient has a clot in the middle cerebral artery, and this patient is subarachnoid hemorrhage. Certainly, we do not treat the TPA with in patient with the subarachnoid hemorrhage. Okay, and so we certainly make sure this is clot. There's no intracerebral hemorrhage or subarachnoid hemorrhage. And then we do the CTA examination. This is one example of the clot. And CTA examination shows certainly left middle cerebral artery is completely occluded compared to the right side. And you can see the coronal view again showing complete occlusion of this clot. If necessary, we do CT perfusion. In case of question whether there's a survival tissue is there, you may do MRI and perfusion scans, which can select the patient better. Once you select patient to go for the treatment, the certainly first step is to give IV TPA, intravenous TPA is given. If patient arrived within the 4.5 hours and there's no contraindication of recent surgery or other contraindications to use TPA, then we take patient to the endovascular suite, the angio suite, and we do all with the endovascular treatment. You can use a stent clot retriever or suction devices, which ordinarily we try to get all the treatment done within 6 hours, since after 6 hours you have higher incidence of the intracerebral hemorrhage associated complications of the stroke treatment. Newer trial of so-called the DAWN trial showed up to 24 hours in selected patient is better to do than medical management. Anyway, this patient, you can see there's a clot and complete occlusion of this middle cerebral artery. This is clot. I was told that later on this was one of the famous guitarists of the famous band in United States in 80s and early 90s. Anyway, he was with his wife. He had a sudden episode of the he suddenly developed the hemiplegia, and he couldn't speak. The wife noticed he has a change, so immediately brought to the hospital. And this is 1 hour, within 1 hour of the event, and angiogram shows complete occlusion of the middle cerebral artery. You can see the clot is sitting there. And so we got in, and we suctioned it out, and this almost 2 centimeters of the large clot from the middle cerebral artery. This is right after the thrombectomy. You can see complete reperfusion of the middle cerebral artery territory, and this is immediately after the treatment. He could not speak, he could not raise his arm, but immediately after reperfusion, you can see his both hands are raising up. This is another patient, had a large clot, and this patient had suctioned it out, and you can see 3 suctioned out, 3 clots, and he had a complete reperfusion of this. Unfortunately, he had a little basal ganglia. This is more sensitive territory in the brain, had a stroke, but major portion of the middle cerebral artery territory was saved by these things. And this is another patient. You can see complete occlusion of the one major division of the middle cerebral artery, and this was suctioning out. You can see the stent was across the stent was placed across the clot, and this was taken out, and this is after the complete elimination of the thrombus, and this is immediately after the procedures. Okay, so you can see the dramatic changes if you intervene and early enough. Unfortunately, some of the patients do not have any recovery or late to intervene. This patient had a complete recanalization, but unfortunately, this patient had a complete stroke of that middle cerebral artery. You can see the MR scan shows complete stroke of this patient. Some patient came too late, and in spite of the complete recanalization, this patient had complete occlusion, the stroke, death of the middle cerebral artery territory. And because of the age, we intervened and we did a craniectomy to give us some space after the swelling. In case of this stroke, you have complete massive swelling, which may cause of the other brainstem compressions, eventually death. But he survived, but you can see the massive large portion of the brain is stroked out. So, time is brain. The Benjamin Franklin said, time is money, but time is brain. It is important to intervene early, and this is mobile CT scan, which was developed by the company called Neurologica near the Boston area. And I was kind of advisory of this company, and we presented the initial result in 2007 of the comparison of the images in mobile CT scan gives you, is a similar or same quality images as a stationary CT scans. So for stroke treatment, time is most important. This is a composite image of mobile CT scan. We made this composite images, putting this inside ambulance. And this was one of the slides I made when presented our result in 2007. But you can see the mobile CT scan is inside the ambulance, and you can see telemedicine images go to the stroke neurologist. His guy is a face of the famous neurologist in Cleveland Clinic. But anyway, this is the futuristic images we made in 2007, but it become reality. Now, mobile stroke unit is available in certain cities in the United States and in Europe as well. This is putting the CT scan in mobile ambulance, okay? And you are actually getting to pick up the patient at the time you pick up the patient, and you make a diagnosis, and you initiate the treatment, so you save time to save more neurons. It is actually the reality. You can see this is one of the mobile CT unit. You can see CT scan is inside ambulance. All the medications are stored to initiate treatment, intravenous treatment with the TPAs. This is one of the images you can see from the mobile CT scan. It's a pretty good quality images you can obtain. And hopefully we will get this mobile unit soon. And in Korea, it's not available now, but we have initiated a new development of the mobile CT scan, and our Sejong hospital will be one of the first units we will receive when it become available under the guidance of the FDA. Okay, hopefully next year we will get it. Okay? Anyway, the speed. Our chairmen and presidents do not know the story, but hopefully we will come in future. Anyway, in our hospital, there's a protocol called the SPEED protocol. When patient arrives for stroke, we'll have a Sejong strategy for the prompt recovery of neurological deficits. What it means is, once patient comes in with a stroke, all other facilities are available to take this patient without delay. CT scan, MR, or hospital, bed, or ICUs, everything is available to manage the stroke patient. So conclusion, to management of the stroke is time. Okay? In case of any symptoms occurs, you call 911. In Korea, it's 119, and to get into the hospital emergency room right away. Thank you very much.